Sarah Walters presenting to us once again. She is an HPCSA registered genetic counsellor and medical scientist. She currently holds the position of principal genetic counsellor at Ampath Laboratories. She has over 20 years of experience in counselling clients in various genetic conditions from prenatal to postnatal, late onset disorders, and cancers, amongst others. She is also involved in lab work analysis in sequencing and array CGH. She has a particular interest in educating other healthcare professionals in human genetics and the intricacies of new genetic testing and their applications. She brings teaching and mentoring experience and expertise from instructing medical students at the University of Witwatersrand. She's also currently the training coordinator for intern medical scientists in genetics at the NRL Genetics Laboratory. She serves as an assessor, moderator, and site assessor for the HPCSA. She has also presented at many local and international conferences. She has worked extensively in both state and private with children, adults, and families with cystic fibrosis. She is currently finalising her PhD. I'm not sure if she's already in. It's done. Fantastic. Okay, welcome once again, and thank you for coming.
Thank you. So I gave this talk to our haematologists a few weeks ago, and Michelle kindly asked me to come and give it again. And it just deals with some of the ethics around haematology testing in terms of genetic diseases and what else, other. So even though you're testing for one thing, you could inadvertently discover something that would have a huge impact on the family. So I have no idea how to make the slides move.
So here, there.
This one.
Yeah.
Here we go. So why should we be concerned about ethics? We are required to behave responsibly towards patients, our co-workers, and to other healthcare professionals. And we have an obligation of conscience rather than an obligation, which sounds a bit weird, but it's all about your morals and ethics and views of yourself, and then also what is relevant from a medical ethics point of view. So the reason that we look at ethics as well is that many people can be accused of various indiscretions, such as fraud, abuse, waste, kickbacks, financial gain by sacrificing quality, and conflict of interest. So all of these you have to be aware of. It's not about practicing defensive medicine, but it's about doing things in the correct way or the right way for everybody. So what is ethics? It's a set of principles of how to behave and how to treat. In other words, appropriate conduction of yourself in terms of treating the patient, in terms of the testing that you do, but it's all about doing the right thing. And I think all of us have got this moral conscience that we know what the right thing is, maybe. Well, I'm hoping that everyone does. In order to do the right things in terms of medical care. So when we have a look at medical ethics, there's lots of things that we need to be balancing. So Lady Liberty over here is balancing morals and ethics. The principle of autonomy is about treating the patient like an individual person and helping them to make their own decisions regarding certain things. Beneficence, so anything that you do for the patient, you're benefiting or you're helping the patient in some way. And then non-maleficence. I always like the picture of Angelina Jolie here because she's Maleficence in that movie, whichever it was called. So to do no harm. And I think those are the ones that are well known. Fidelity is about being true to the practice of medicine and your morals and how you deal with certain situations. And veracity is about telling the truth. So I know that sometimes things are sugar-coated, but as long as it's the truth and not trying to sway someone away from the truth, then that should be fine. Justice is about treating people in the way that they need to be treated. So often I look at, there's a diagram that I look at where you've got short people trying to look over at a soccer match over a fence. And so justice is about helping the shortest person to be able to see over the fence by giving them 2 boxes, the middle-heighted person 1 box, and then the person who's tall enough already and doesn't need a box. So each person needs their individualized kind of treatment. I should have put the picture up. And then deontology is the principle of knowing what is right and what is wrong. So yes, it does depend on your internal morals and how you treat people. So in genetics, the ethics that particularly go around genetic testing include informed consent, incidental findings, which I can explain a little bit further just now, variants of uncertain clinical significance, of which we get many, the psychological burden of uncertain results. So if you give back an uncertain result, how is it going to impact on the patient? How's it going to impact on the treatment? And how's it going to impact on the family? What does it mean for them as a whole? Confidentiality, I think that we all used to, and privacy. So it's about giving results back to the patient, and especially now with the POPI Act and all of that, I often get wives phoning in or grown-up children that want to know what the parents' results were. And the thing is, unless you get permission from the person who's affected, you can't give those results out to them, even though it may have an impact on them. So it's up to the person who is affected to distribute the information amongst their family. And in genetic counselling, we encourage that, and we give them ways and methods or suggest ways in which they can share the information. So looking at genetic results, things are not as easy as they used to be. We used to either get a mutation or it was normal. That was it. It was a straight black and white. Now, not so much, because when we look at every single variant, so remember when we do genetic testing, what we do is that we compare whatever the sequences of the patient against what we call the reference sequence. And anything that is different from the reference sequence, whether it be a polymorphism or a SNP or whatever it might be, you still have to investigate it to see if it's going to have an impact on the patient. So the easiest ones to look at are likely benign and benign, because it means that they previously have been shown to not have an impact or cause the condition that the patient has. And then on the flip side, the pathogenic variant is pretty much like reporting a mutation, something that's known. Likely pathogenic, there's some evidence and quite a lot of evidence to say that that the variant that has been found is probably contributing towards the condition. So a pathogenic variant will have evidence that's more than 99% causative, whereas a likely pathogenic has enough evidence that's 95% and above. So they're still in their 90s, which is pretty good. However, the variants of uncertain significance fall right in between that. And that means that there's a variant, so therefore there's a change from the reference sequence. And nobody knows at this point in time what impact that has on the condition. So we use various tools like predictive software for where the change in the gene is it in a protein domain? Is it near a splice site of the intron and the exon? All various things to try and predict what the effect of that variant might be. However, there's often in fact, there isn't enough evidence, and therefore it will be classified as a VUS, as I like to call it. So people who speak Afrikaans always laugh at that one. And that one's a difficult one to sit with, because where does it leave your patient? We found something, but it's a VUS, so therefore we can't treat you on a VUS. So we're just going to have to sit and wait and see if anything changes in future. So when more evidence is available, a VUS can get reclassified. So in our experience of having done many panels, what we found is that about 80 to 85% of all VUSs subsequently get reclassified into likely benign, and few get reclassified into likely pathogenic. And the ways in which we help families in terms of trying to determine if we can shift the classification is by testing other family members. So if you test a family member that's affected versus a family member who's not affected, and do they have that change or not? So if there's someone who, or maybe there's several people who also have that VUS, but they're definitely not affected by the condition, then we've got more evidence that we can call it likely benign. Obviously, depending on what is the condition, what is the gene, what is the penetrance of the gene, etc. So lots of factors to consider. So even within our VUS range, we have what we call cold VUSs and warm VUSs. So a cold VUS is more than likely going to become likely benign, and a warm VUS, especially quite near the end, is really tipping on the edge of likely pathogenic. So, like I said, it just depends on how much evidence you have. So, when is the last time everyone looked at the HPCSA ethics books? Silence is the loud reply. There are 17 ethical guidelines books for HPCSA. I'm used to them because our students, our intern student scientists, need to have a look at them. Well, they need to answer questions around them, actually. So there's just a general ethical guideline to start off with, but the ones that I felt were particularly important in terms of genetics was book 4 in terms of informed consent, confidentiality, and then there's a whole booklet that deals with human genetics and genomics in terms of what we can and what we can't do. And, you know, it deals with experimenting on embryos, and it deals with, all biological warfare, changing people's DNA by doing all sorts. So, it's quite hectic. And then research ethics. So booklet 9 would have come in very handy way back when people you did your research, your meds, or whatever you do. Okay, so research ethics is a really good book. So our interns need to do a mini research project in their second year. So very important. And then the use of the internet and social media, which is, it's not new, but it really addresses some of those unknowns in terms of how we use things ethically and in order to assist our patients. So if we have a look at booklet 8, one of the things obviously for me is the right to genetic counselling, and it doesn't matter what genetic condition it is, that they should be offered the option of going for genetic counselling. And especially if someone does not have a lot of information regarding the condition or the genetic influence, or specifically about the gene that is maybe causing the condition. We have a duty to warn. So in other words, this is when I was speaking about family members. So we have a duty to warn other family members, but yet we have to maintain the confidentiality of the patient. So that's why in genetic counselling, we always try to help them find ways to tell their family members themselves. Equitable access to testing. So everybody should be able to access all genetic testing, which we know is not true. The NHS labs are going through a difficult time, and so a lot of testing that they have previously offered is not being done. And then we come to predictive testing and prenatal testing. So These are always difficult and very emotional types of counselling sessions. So predictive counselling would be for something like breast cancer or a particular cancer in the family, or it could be something like an Alzheimer's, Huntington's disease, something that's a later onset condition in the family as well. And so prenatal testing, obviously, there's lots of emotions that surround prenatal testing. So we've got to be careful, and we've got to make sure that any genetic result is correct, because life-changing decisions can be made on the basis of a genetic result. And then there's some guidance about how we use new technologies. And sure, it's difficult to keep up sometimes because genetics really is developing at a really fast rate in terms of new ways of doing things, in terms of faster ways of doing things, in terms of the technology, what can you do with it and what can't you do with it. So it all depends on the gene that you're looking for and the mode of inheritance and the penetrance and lots of different things. So I had a look at a couple of case studies that I thought would be interesting, and I asked questions in these, which I expect my fellow room members to participate in answering. So the picture on the left is breakage studies. So when we do chromosome breakage studies, we induce breakage with, I've forgotten what it is. I haven't done it for a long time. No, we don't use that.
You don't?
No, we don't. Anyway, what you can see in the metaphase there are lots of breaks and gaps, and then rearrangements that are called triradials or quadriradials. So that's where chromosomes that usually should have nothing to do with each other actually join up. So we get a prenatal sample and we know that both of the parents are carriers. So are they carriers? So they must have been tested from a molecular genetics point of view. In other words, we know exactly what the change is within whichever gene and whichever population group this is for Fanconi's anemia. Because we have, in South Africa, we have 3 types of Fanconi's anemia, not 3 types, but 3 different genes that cause Fanconi's anemia. So we've got Fanconi A that we find in the white and the Caucasian and the Afrikaner families. We've got Fanconi C that we see in the Ashkenazi Jewish families. And then we've got Fanconi's G, which we see in our African population.
I have a problem with this testing. Because it doesn't include the Asiatic origin.
It doesn't.
And I had patients like that, and you're stuck because you can't test them. There's only these 3 being tested and offered in South Africa, and yet Fanconi's is there in these population groups.
And yes, it's also in Durban.
Yeah, no, Asians are interesting. Generations in Johannesburg, but you can't test them.
Yeah.
Okay, we have to develop one.
Yeah.
That's the problem. So do you know which gene?
So I did remember. I don't
You
remember.
don't remember. Okay.
Yeah.
So if both parents are carriers, the amniocentesis reveals that the fetus of is a carrier as well. How do you report this?
My question is, why do they do this test? Is it standard or not?
Fanconi's anemia.
It's not.
Yeah.
As part of
It can
the
be done as prenatal.
Can you?
Yeah, as
Okay.
long as you know what the parents' pathogenic variants are.
So they did know that the parents had.
This is just a made-up
Okay,
case.
sorry.
Just decided to pick Fanconi's because I've worked with it a lot when I was in cytogenetics. That's
Now
not
you're in
real
trouble.
So what do you report on this? Do you report, because they're obviously doing the testing because they don't want to have a child with Fanconi's anemia. Maybe they had a previous child, right? So what do you report on? Do you report that the fetus is not affected? Yes.
No,
Okay.
because you know, we know that medicine is a science of probabilities.
Mhm.
So you never know. So the question that you regard as likely or unlikely, isn't it? Where you believe it would, because the test is not 100% certain.
No, if you do the molecular testing, it's
Yes.
pretty certain.
Okay, then you could tell them yes, good news.
So my question, that's where my question came up from, because I saw that question come up, because why did they test it in the first place?
Yeah.
Surely they have an index of suspicion, so they're ready for that kind of an answer.
Not prenatally. So maybe they had a previous child who was affected.
But the fact that they're
So maybe the
testing
chance I have
it,
in the next one.
But then the parents got tested to see that they were both carriers.
yeah.
Right? So now they're doing a prenatal.
But what I'm saying is they knew they were tested. They
Right.
are carriers. That's
Yes.
why this test, I'm
Yeah,
just leading on.
right, yeah.
That is why this test was done specifically for
Yes.
this patient. I
Yeah.
mean, the prenatal sampling.
Mhm.
So obviously a counseling must have been done or should. So they should be ready for the answer, which is a carrier or homozygote.
So there comes my question is, should we be reporting on carrier status for a fetus? Because the fetus has its own autonomy, and do the parents have a right to know that as a child, that child is a carrier of just one pathogenic variant, so therefore it's not going to have impact on them growing up.
So you're saying ethically, should the fetus's status
Autonomy.
be disclosed to the parents?
Mhm.
The fact that it's being tested,
Mhm.
that they have spent money on this testing, that they
Yes.
deserve an answer.
So the answer is that the fetus is not affected,
The
But
fetus is a carrier.
not affected. And the-
can it be a carrier then?
Pardon?
Can the fetus be a carrier?
Of course,
Okay.
just
So-
like the parents.
Why do the parents need to know if the fetus
This-
is only a carrier, it's not going to impact their life?
Because
they
they
have to
shoot
be-
their spouse, they must test their spouse before they get married.
Grow up and the
Yes.
child is going to get married. At
Yes.
some point, this is going to get shoved under the carpet and the child will be in the same situation that the parents are currently.
But the child knows that there was a previous child born with Fanconi's
Doesn't
anemia
matter.
and then can get tested as an adult.
Yeah.
An autonomous decision to get tested as an adult.
And they shouldn't have done the test in the first place.
But what if the fetus was affected and then that would have terminated the pregnancy?
But that's exactly it. It's a carrier, it's not affected. Surely they're entitled to that information.
You see why this is such a good ethics question?
No,
Because what is the right thing to do?
For the child to know.
It's for the child to know.
Parents need to know.
It's the parents
It's
right
the
now
child that
needs
needs
to
to
know,
know.
but
I
they are
think
the
the
ones.
parents need to know.
No, why?
Why? Because they
Because
pay for
my
it.
issue that at the end of the day, it's gonna affect my I don't know, where's the child? The child get married.
It's not going to affect the child growing up.
But carrier, then I would also need to tell my child that listen, your carrier means whoever you
So
find.
Ampath then phone the child when they're
Or the child sitting in country.
and tell them you're a carrier.
No, that's not practical. But the problem is the
Yes.
parent needs to know, and it is they are parents.
Mhm.
They have rights,
Mhm.
they have responsibilities. So this is going towards the responsibility component. It is my responsibility to inform my child that this is what you have and this is the potential in the future that you need to look out for. And that would guide the child in the future.
But what if the parents, after giving birth, died immediately, but all the parents? What happened? What then happened? Because the child won't know, isn't it?
The child wouldn't know.
And then
Okay, so basically telling us that don't test the child, but the test is done to make sure that whether she's a carrier or Fanconi. Now,
No, I'm saying this prenatal test was done to find out if the child was
Yes.
affected. Right?
affected.
So that's a yes or no answer.
Yes, the answer is if he no affected,
Yeah.
you still need to inform the child because there would be a family history to say that.
Exactly.
Yes,
There'll be a family
History,
history
and they need
it
to
would
know.
be recommended because
Yeah.
the parents are carriers, right?
exactly.
You have an obligation.
You got to
So that's why it's so difficult. So we
that's
sit in
why
the
I say
lab
you
and we
shouldn't do
go,
a test if you're not ready for the answer.
I agree.
And you shouldn't do a test if the parents are not given the ability to make a decision, because they're not going to make a decision and terminate the pregnancy if the patient is positive, right? And is not a carrier.
Yes.
What about the fetus's rights then?
Mm.
You know what I'm saying?
Yeah, for sure. That's why
Not
it's such an
straightforward.
ethical dilemma,
Yeah.
right? And then what else should we, so if we do, let's say, for example, that we do report on carrier status, what else should we be reporting on or warning of?
The potential, whatever,
child.
you know, for the child, the
Okay.
implications on the child.
What else? Silence is the loud reply. So people who are Fanconi's carriers have an adult risk of developing cancers like breast cancers and all of those. So should we be putting that in the report?
The answer, yes, they need to
Yes,
know.
you should.
So exactly. So it should have gone in the report when the parents were tested as carriers. Then that type of information should have been disclosed at the time. Yeah.
But now, if that child grows knowing all this information, they said, I don't want to get married, I don't want to do because I'm going to die of cancer and everything. Isn't that also the fact that knowing something that might, that have probability of happening or not happening, now impact his decisions in life
Exactly.
about what to do?
So
That's
it
why
needs
counselling
to
should be counselling. It should be offered as a mandatory.
It's not mandatory.
It's not, I know,
Not
but I'm
on
saying
the
it should
and
be
that's
be
the
offered.
So what we've experienced a couple of times is that people refuse to come for genetic counselling. They absolutely flatly refuse. And then they get a result.
type of a denial or a
It could be because maybe we don't see them ever, or it could be an extra expense when they've already got lots of expenses in terms of testing. We don't know what the reason is that people refuse to come for counselling, because they often say, oh, well, we know everything, because they've lived or have read about the condition, right? Then sometimes they don't understand what the consequences of the result are. So if I ask any practicing clinician, what does a VUS result mean? How are they going to explain? And I don't.
wow, something. Does a patient have like other tests? Does there always have to be an associated doctor? Or
Yes.
you can never like just go to Ampath for testing?
No, you can't. It has to be done through a medical doctor because the results have to go back to a medical doctor. Some patients contact us directly, and then we say, well, who knows about this condition in your family? And then we encourage them, either if it's a gynae or the GP, we encourage them to talk about whatever.
But those doctors don't necessarily have the knowledge to.
No, they don't, and then they're quite happy to refer. Okay. All right, so there we go. So that was the what else. Okay, so here's all the Fanconi's genes. So quite a few then. So Fanconi's A. So remember that BRCA2 is associated with Fanconi's D. Yeah. And then Fanconi's A. But all of these genes are somehow involved with DNA repair as well, because remember that Fanconi's is a breakage syndrome. So they're all involved in the DNA repair pathway. When I studied Fanconi's, it went up to Fanconi J, and now it's gone up to about Fanconi VW. W. No, but not a car. Yeah, so that was how many moons ago. All right, let's talk about informed consent. So when patients sign a form, how many of them actually read it and ask questions?
The question is how many doctors actually read that information?
So reading a form and understanding the information is not always the same. And that is a huge challenge, because even when I ask them to sign a consent form that they want to have genetic tests done, they just sign it. I'm going, no, but you haven't read it. You need to read it. Please have a look through it. And sometimes they just want to sign and get it over and done with, but they don't understand the information in the consent form. And then also with some of our genetic testing, depending on what is done, there are other options like please report secondary findings. Please report incidental findings. I don't want to know if I'm a carrier for something. All of those types of things. So there's also tick boxes that they have to read it. They have to understand what they're letting themselves in for, and then have the opportunity to be able to answer questions. So, yeah, the fact that it must be voluntary, obviously they would want to have the genetic testing done. I've had some people come for genetic counselling with a strong family history of breast cancer, and the gynae or the parents, oncologist, whoever sent them for genetic counselling, and we know that there's something in the family, and some people have decided not to test it. I said, no, they'll take their chances and see how things go. So genetic information is not always helpful, because some people think that they're sitting with a knife, but a what or something.
Knife over their head, yeah.
Yeah, that something definitely will happen. Whereas if they don't know, they might have other choices.
It's bliss.
Yeah, it is sometimes. And so obviously informed consent, the special considerations for prenatal testing and for incidental findings, whether they want to be informed about that or not. And then consent forms also need to mention the limitations of the test. So this is what the test cannot do. You will not get information about this, that, and that. So often people ask, if I do a test for cystic fibrosis, will it tell me if I'm at risk for breast cancer? And I'll say, no, the test is specifically designed just for the cystic fibrosis gene, and you will not find out anything else about the rest of your genetics. Okay. Okay, another case study also made up. Qualifying it before I even start. Okay, the myelonxoma panel was performed on tumor tissue, and a TP50, there were TP53 variants, and one was detected at 47.5%. Does that mean anything to anyone?
47% high. Even 1% is still high. So the probability are there.
So 47, would you say that 47.5% is close to 50%?
Yes.
Okay. And when you're looking at genes, what happens if you carry a tumor suppressor gene? You're going to have one pathogenic variant, right? So this would indicate to us that it's possible that this person has got a predisposition because they've got a TP53 pathogenic variant, which they were born with. So what we do after this, so what to do next is that we request peripheral blood, so we can then see if the person is a carrier for a cancer predisposition gene.
So, but there's a chance of 50% they might develop the disease or not.
No, that's to do with the penetrance of the gene. The 50% is that you've got two TP53 genes. One of them has got a pathogenic variant and the other one doesn't.
Yeah, so
that's what.
And clinically, what happens to this patient?
So that's the question. Yeah. Are they at risk for things like, so this patient came in for, I can't remember. Oh, I made it up, that's right.
What does it bring?
Random.
Because
They had myeloma.
we have a problem with the patients like this who come with these all test results with some of these genetic tests that were positive.
No, you don't know.
And they wanted you to look for this cancer because my genes say having this, I need to have cancer now. And of course, with psychological involvement, they now feel the symptoms of those diseases.
Yes.
And the question that those genetic test excerpt does not say you're going to develop the disease with certainty.
Yes. Yeah. And that's the whole thing about tumor suppressor genes, is that it's not 100% that you definitely will develop cancer related to that tumor suppressor gene.
And even when.
Or when, or how,
Or if,
or where. So remember the TP53 gene is involved in DNA repair as well, and it's the guardian of the genome, right? So DNA repair is sort of conducted, and if you've got one faulty gene, is it going to repair properly? And it all depends on the type of repair mechanism that gets used. So what you do next is that you offer germline testing. And then what is the patient at risk for? Well, you have to have a look at the family history because that can give you clues, but it doesn't necessarily say this is the cancer that you're going to develop. So we have to look at all the cancers that TP53 has been associated with. And then how will you discuss it? Say you're at risk for other cancers, so this particular myeloma or whatever the case may be, but you're also at risk for other cancers. That's not nice news to hear. So breaking bad news has to be done very sensitively. Yeah, so then if a parent who's say 60 develops this, then what?
16.
I'm just sucking at an age.
I think you need to monitor HPC's
My,
risk for
yeah.
10 days.
Great. From a hematology point of view,
What I,
but from a genetics point of view,
my question is that this patient was diagnosed with a malignancy,
yes.
and it was found that he has this TP53 gene, which already confers a poor prognosis to whatever malignancy he had. So it can behave as a high risk
Mm-hmm.
malignancy. So that is something that needs to be,
Discussed.
yes.
Okay. What else?
But should we actually warning patients about this? Because I mean, if we told you the chance you're gonna drive, you're gonna die on car accident, does that mean you must stop driving? Or should we be assessing you all the time? The answer is no.
So it can guide further management in
Yeah.
terms of how often you screen.
What about the
pregnancy.
cost implications?
See, the thing is, I think my thinking is that I have a patient who's got a high risk
Mhm.
malignancy.
Mhm.
I would offer them the more aggressive treatment option and push, they would be a transplant candidate immediately. Like as soon as I get them into remission, I transplant them. For me, that makes clinical implication, that has a clinical implication.
Right.
You know, and they have to be aware of the fact that because of this genetic mutation, they may not respond ideally to treatment.
Mm.
And I think that is fair to do that with the patient because they must understand the, prognosis
Yes.
and make preparations accordingly. You know, I mean, that's just from a realistic point of view.
Mhm.
So I would prefer to tell my patient.
Okay. Any other suggestions about what else should be done? All right. Does the 60-year-old have any children? Are these children at risk of inheriting this TP53 variant, which we know is germline? Yes.
Yes.
So every child, because it's a tumor suppressor gene, it's inherited in an autosomal dominant manner. So it means that every child is at risk, a 50% risk of inheriting the same. So then, should the adult children be tested? Yes.
So I had a very similar scenario
Yeah.
with my patient. They had a germline mutation.
Mhm.
And the discussion was had, informed the patient, the spouse, and he informed his family.
Mhm.
And we welcomed them to come through to us to test,
Mhm.
Family refused. Outright blatantly refused, but at least they were informed.
So first
And
of
they
all,
made a decision.
they made an autonomous decision, exactly. So they didn't want to know if they were at risk,
Exactly.
and that's their choice. But as long as they understand and what the chance of inheriting, what disease it may cause, and also what is the risk then to their children, to the 30-year-old who's having children. I like to leave everything hanging on a cliff because there's so many decisions that have to.
I don't think there's a right or wrong decision necessarily with
It's
that,
got to be an autonomous decision
Exactly.
by the person who may or may not want to be tested.
but they have to be informed.
They do have
That's
to be
the most
informed.
important.
Yeah, absolutely, I agree. Yeah. Okay. Oh, I've got one more. DDX41
Yes.
was found in a mother with AML on the imaging panel, and the mother's got two pathogenic variants, one of which is at 48%. So same scenario. could this be an inherited germline mutation? So all 4 daughters were tested for carrier status and 3 of them were positive. So what happens is that they are at risk for NDS and AML at a later age.
Question that. Who will be doing this test for these patients? A question that what are the chances that in this room, if we all do tests, we have carrier of some sort? How would that impact their life going forward?
We all carriers of something.
Exactly.
Of
The question
something
that,
that
should we be worried? Or should we be worried about something that is not there? Because human being inherently sick.
The thing is, it's your choice. If I want to worry about it, then I want to know if I have the right thing.
So I want to know about it so that I can go for screening earlier? So if there is anything, you can catch it at an earlier stage, and maybe it's easier or better to treat at an earlier stage than a later stage.
And even despite that, some people will choose not to know. We can't choose for them.
That's why it's like a dilemma.
That's why I run it away. Actually.
Okay, so the question is, the adult children were tested, and should we be testing the next generation down?
The answer is, of course, it depends.
So are children at risk?
Well, the principles that if you have tested this one, then you have to carry on to the next generation, because if you know there's a risk and the family already know that is a problem, then they need to go. It's like someone factor 5 deficiency. Now, if you knew it, the question that can my children be tested? Yes. But next generation be tested? The answer is yes, because the risk of PE are very high. So it depends on the conditions.
It does.
High detrimental to the next generation. Like if it's a cancer, breast cancer, then they have to continue testing. But if something that is mild, then probably will be different. I don't know, but I think they have to be kind of high detrimental the condition for the next generation.
Right. So the DDX41 gene has between a 30 and 40% penetrance rate,
It's high.
which means that people who have got the one pathogenic variant, 40% of them will develop disease and 60% won't.
Majority won't, but still, it's quite high.
So your version of high in terms of risks
Yes.
is different to the next person's version of what is a high risk.
Yeah.
Yeah. So when I used to do prenatal testing or offer prenatal testing for amniocentesis, say, for example, for advanced maternal age, I used to say to them, okay, the chance of you having a baby with Down syndrome at age 35 is 1 in 356 or whatever. So that's a 0.something% risk. However, the risk of you having a miscarriage because of the amniocentesis is 0.7%.
And then the risk is nil if you have a baby at the age of 16 to 18.
No,
Not nil. Never know.
no.
Never know.
In fact, at the age of 20, the risk I think is higher than at 25. So a younger age of pregnancy. So I think
It has a risk for?
Down syndrome,
Okay.
like any woman has got a risk.
Yeah.
Right?
Nobody's going
So what happened was that they heard the risk, and maybe it was a 40-year-old woman whose risk is 10%, let's say, for example. And then you give them the risk for miscarriage because of the amniocentesis, which is 0.7%.
and they feel it's not worth doing.
Exactly.
Yeah, and then they say no, because 0.7% risk of miscarriage to them is much more important to them
Yeah.
of losing the pregnancy versus a 10% risk of having a baby with Down syndrome.
Because remember, this is an older woman who's already got so many other risks involved. You don't want to lose a baby from this.
Then she can lose a normal baby.
Exactly.
Doing an
Exactly.
amniocentesis, trying to find out if they are.
And she may not have another baby.
Yes, exactly.
Okay.
So people's views of risks are different.
I think that's the issue, the question that people sometimes look at the risk, but am I worried about it? Because they read it about, this is my thinking in life. If you're already well-worn about risk, you are likely to manifest the disease. Psychological or might be realistically. You know, the scenario is like having a snake, there and you walk around because you don't know there's a snake. The snake also lie, no risk for you, you won't get bitten. But the moment you knew there's a snake, chances are good that the snake also can feel you and bite you. So the same thing for me, I feel the same for genetically test. Now, if I knew that my risk of colon cancer high, chances are good that I might actually then develop colon cancer.
What's high? What's a high risk?
Well, that's
Good.
whatever is high for you.
Exactly.
But I think it also depends on the personality type.
Oh,
Because some people will, okay, I'll go for my regular screen. Other people will become paranoid, who already are paranoid. And now it is just, and they live in fear and they go from doctor to doctor, from test to test to make sure that nothing is wrong with them. So that's the other option. That
And
you're-
then the
Parents were diagnosed with cancer. Siblings were diagnosed with
Yeah.
cancer.
because we have a patient who was paranoid about colon cancer.
Mhm.
And he went colonoscopy almost every 2 years. And then few months there, he died of gastric cancer. Because he wasn't worried about gastric cancer. So now everything they did have about 10 colonoscopy was from Lipalala. But now nobody did gastroscopy for him because it was perfect. And then he died of gastric cancer.
Time and time again, where somebody is like sort of extremely worried about a certain medical condition, for whatever reason.
And then
that's
others say ignore.
first.
The question is, should we not be looking at the patient holistically? The question, that's where we should be thinking about. And also, maybe we should also be kind of saying, instead of focusing on one particular issue, can we not look at the patient holistically? Let's say patient have a risk of scleroderma. The question that, can we not focus on scleroderma, or can we looking holistically at other conditions that can actually come and look at the patient as a particular human being?
Because the problem is also now, if for instance, you as a doctor get sidetracked by the risk for cancer,
Exactly.
and then you miss the diabetes and hypercholesterolemia.
all the other things.
Yeah, because your patient, yeah.
Yeah,
You have
so-
to.
So I mean, the other advantage of doing genetic testing is that if you know what the gene is that's involved, there's various cancers that it could cause. And so yes, maybe you would increase your screening. Some women choose a prophylactic double mastectomy when they find out that they're BRCA positive, for example, because they've seen, and it's their own experience of having seen women or even men in their family who've had breast cancer. Maybe they've looked after them, maybe lots of pain, etc., etc. Whereas someone who's a little bit distant from it, maybe a cousin who's at risk, they haven't seen the daily nitty-gritty of what happens when someone has a cancer. So their decision might be quite different.
It's like your perception and interpretation of the information
Yeah,
given to you is going
Yeah.
to
yeah.
change your decision.
Thereby emphasizing the autonomy of individuals.
What about the advantage of all this? Because obviously, look, like for instance, I'll tell you, there are people probably, let's say they're having rare genetic imbalance, say, of the, let's say the connective elastic tissue disease like that and all those. But then there's advantage where they could actually do very well in certain kind of spots.
At the risk of damage.
Yeah, exactly. That's what I'm saying. But I mean, there's what
Yeah.
there's that the question is that why do you focus on? Because can the bad be good and the good be bad? The question
It's bad, but you've got to make.
it's the question that can't you look at the positive aspect of it also?
Yeah.
Yes.
Do we have to be always have to be prophet of doom saying this is what happened? Or because there's some positivity in every genetic of human beings.
Of course.
Yeah. So the question, how do we make sure that we create that balance that the actual we don't look at the risk of cancer, but we also must look at other genomic aspect of this person where they can also be very strong. Because then the human will be born and die. That's our spectrum of life, isn't it? So the in between.
Guaranteed.
Yeah.
Discussion.
I think it's going to be quite different in 50 years' time
Yeah.
because tests are getting more sensitive. People are going more and more for it. So you'll be confronted a lot more with these questions.
Yes.
So
People, they're offering these kind of screening tests for different types of malignancy, the whole panel. People are willingly paying for it to screen themselves. What do we do with that?
Yeah.
information.
Mm.
Some of the things we haven't even had, we don't even have the knowledge of the associations. I mean,
Mhm.
it can be this chemical that's high in your body and this one that's low, and suddenly now that causes a risk for cancer.
Yeah.
I've seen patients, they come to me with these results and say, you know, I'm being seen by this is high, this gives a, you know, risk for this. I'm like, oh, really? Okay. Themselves, luckily. You know?
Yeah, wait to Dr. Google first. Okay, so remember that there's a difference between somatic testing and germline testing. And I've put the DNA repair pathway there, although it's very small and I can't even see it properly. So lots of the genes that are on cancer panels obviously are in the DNA repair pathway. And I've just listed a few of them. This is a few.
Now, as a genetic specialist, just a simple question.
It won't be from you.
The question that we know that there's a lot of environmental, our environment
Mhm.
affect our progression from childhood
Mm.
to adulthood. And obviously, we know also the process that your food, your exposure, whatever is there, can in fact about your repair of your genetic materials. So then people get diagnosed with kind of conditions and then they actually outgrow it, like in terms of the asthma. You have high likelihood that you will develop allergic asthma.
Mhm.
But then, of course, because your environment, or you stay in Netherlands where there's non-allergens,
Mhm.
so you find that you actually don't have this problem.
Yes.
So the question that would the environment and all those, despite us obviously giving the patients all this perspective,
Mhm.
but we shouldn't be looking at also say, perhaps what had happened to progression of this particular human being over a number of years,
Yeah.
that this condition that we predicted might not actually be, yeah.
So environmental exposure is definitely something that we always talk about, because if you think about tumor suppressor genes and the Knudsen's 2 hypothesis, that second variant in a tumor comes from in somewhere, like DNA damage from somewhere, right? So we talk about sun exposure, we talk about radiation, we talk about pesticides, we talk about stress, all of those things. But the problem
But
is,
food we eat from what the farmers are using.
exactly. So how do you quantify that though? So if you've got 50% stress, that I don't know how it's measured. If you lower it to 40% stress, will it be more protective?
Yeah, but that's
If you eat from the farmer's market versus food in the shops, will it be better because maybe it hasn't been exposed to environmental chemicals or whatever they're spraying on crops? Or are you in a high stress job where every day you're completely frazzled? Is there a change that you can make that will lower your stress from that? So yes, lots of environmental factors that can't be quantified. Plus, you also have to have a look at the genes, because the penetrance of the genes has also been quantified in many of them. So some of them, if there's a high penetrance, some of them got 100% penetrance. By the age of 50, you will have. So something like, completely off the topic now of hematological, but autosomal dominant condition like Huntington's. If you have a faulty gene, you will get Huntington's. That is a certainty. Whereas if you've got another gene that's only 20% penetrant, there's a good chance that you won't get it.
yes.
Yeah. So those are the things that you have to look at from a genetics point of view as well. All right. So when to refer and when not to refer. So yeah, we deal with genetics. It doesn't matter what it is. You can counsel. It might be a counselling session around coping skills. It might be a session around the impact of this genetic condition on the family and how they're going to tell the family, and who is at risk. So obviously we draw the family trees and who's going to be at risk and who's not at risk. So that also helps to identify and who, and there's many families that I draw that it gets reported that they don't speak to that side of the family.
Yeah.
So that they'll tell this side of the family, but they won't tell that side of the family. It happens.
Yeah, they'll-
Because I remember I got 2 banks. Never one.
So the question is, who can counsel and who should counsel for germline variants. So obviously what I do is genetic counselling. So yes, we can counsel, but if doctors are well informed about the condition, the gene, and how to counsel non-directively, then doctors are more than capable of doing it. There's no reason why a doctor can't be doing it. And that's why the education of healthcare professionals is so important to say, well, you might not know about it, but you can certainly look it up and you can certainly contact us and just ask us to help or find papers or whatever the case may be. So genetic counselling, sure, but there is only 30 of us in the country. But I fully believe that doctors can do their own genetic counselling. So I'm just going to be very sensitive about the way that they deliver news and look holistically about our patient and their families. I think that's my last slide. Yep.
I think
So
look, it's a very exciting topic. I'm not so sure about whether we frame the heading of this topic actually right. The topic was framed as ethics in hematology
I know.
genetics. And that I think the framing is not right. I think the framing should be actually genetic counseling in the context of hematology. And I think because we need to look at more genetic counseling because we need to be able people to understand this more really about counseling and everything. Because we're not worried about the hematology per se, but the question how do you actually navigate through the ethical dilemma in genetic counseling? Because the issue that's where doctors actually fall behind. Because yes, we want to give the patients. My principle of practice always been one. I need to give answers to the questions to the patient. Now the question that, but little do I understand that actually giving answers to the questions, what are the implications to the patients and the spectrum of their loved ones, because now, and that becoming hematology. Now the question, if you say, like, you have a risk of myeloma, like MGUS. MGUS is a perfect condition. We say you got MGUS. The question that does that only attribute to these patients? What happened to his offsprings? What happened to his, going forward? Do we now must cancel everybody and everything? Does he need to tell the rest of family tree that I got MGUS? So it's there's more to it actually that a lot of questions have been done. And as a doctors, we don't do enough. We don't do counseling enough because we just want to give it a diagnosis.
But it's also, it probably falls more on to hematologists and oncologists because they are the end of the line. If you get diagnosed with a malignancy, you refer a patient to oncology, then they get the results, and then they have a discussion about treatment plans, about genetics.
yes.
So that's probably
How often do you send your MGUS patient to hematologist?
That's always been my
The question, you don't.
I don't expect someone who specializes in something totally different to be able to target and treat and monitor every single hematological condition.
Yeah.
You can't. And that's why if ever there's a doubt, refer on because there's a specialist who studied for that only. That's their job, that's their bread and butter. Just like you're a specialist in your field, the same way, just refer them.
I think that's
Because I might see the patient 1 in 6 months, once in 3 months, once in 1 year, depending on the risks that
That's why you have to have centers of excellence around it. I think with any event, I think you can't be in silo. You have to have centers where people actually work as a group, not as an individual.
Yeah.
I mean, do you do it in rheumatology? Do you deal a lot with the genetic counseling and
So far, no.
Should you be dealing with it?
Yes.
Yeah. Why genetics not coming in?
Yes, it's to do with well, if you look at just antibody testing, majority almost don't have the disease.
Right, that's-
But what does that mean?
So that's why the counselling is a bit, or the genetic testing might be a bit dangerous.
But Michael, what are the chances
You
that
can't prevent the disease.
exactly that a patient come to ANA that is 1 to 80, no other symptoms, and you will say, okay,
Okay, it can
patient
be
is
1
fine.
to 2,000.
Yeah, exactly, with no symptoms.
Doesn't matter.
And 6 months down the line, they come with interstitial lung disease with all full-blown disease now. The question that
Not straightforward.
when do you draw the line that actually how confident should you be to say that listen, you find rheumatologically, but in 6 months after the pulmonologist tell you we miss all the symptoms. The patient now got complete lung failure because of that, and that's positive.
You must know, that's why you must examine your patient well.
I think it's easy for doctors to be quite biased in the counselling because, I mean, you can tell the NGAS patient, look, it's normal. It's normal part of aging. And you can say to the breast, the BRCA gene, you know, you should really have a double mastectomy because that's your solution to this. And all you can do.
But then that
So I don't think we're always educated or like in how to counsel, how to be provide information without being directed in the treatment choice or
can I ask you a simple question again?
sure.
Do you think you can do
Crash course.
1 minute or 2 minutes about genetic counseling? Obviously that, yeah, but something that
25 years, yeah, for 2 minutes.
exactly just to say what are the do and don'ts for the genetic counseling? How do you explain about it? You know, just to say that this is like guidelines saying that this is what you do and blah blah. You know, obviously something that to educate our publics and also I mean our colleagues.
Yes,
I think it's possible, isn't it?
I think it is possible. That's my whole PhD.
Thank you.
So, what's important from a genetics point of view is to document the family tree. And I would recommend that you actually draw the family tree. And I don't know if everybody remembers how to draw squares and circles and how everybody is connected to each other, because when you draw it in that kind of manner, what you can see is the pattern of inheritance coming through the family. If it's an autosomal recessive, there's possibly nothing in the family. But if there's autosomal dominant, there will definitely be people that are affected. And it's so easy to see on a pedigree. So drawing a family tree, in my opinion, is ideal. Lots of doctors just make notes about family histories. And then like it's documented, so they often don't do anything else about it. It's about, so genetic counselling is about education. So education about the condition, education about the gene or genes that are involved, education around genetic testing, options around genetic testing. Would you want this or that? Or this is what I would recommend because of the family history. And then they can decide if they want to be tested or not. And if they do, then obviously testing is done and then you give them results. But before even the results come out, you give them the options of, so if you do genetic testing, what can be done? So, I've heard from many doctors that you can't change your genetics, so therefore we should just not even test. There's no point in testing and there's nothing you can do, which I don't quite agree with. So educating and exploring how the condition has affected the family as a whole, what their role was, how it's impacted on them, what is their view of risks, high risks, low risks, those types of things, to enable them to come to a decision about the genetic testing. Some people come in and they say, we want answers. So a lot of people think that the genetics is going to be an answer, and then we get a result that's got 5 VUSs and nothing else. So then genetics is not an answer. So there's got to be more in terms of further management going forward, further care for the patient. So all of those things are explored, and then obviously when we get a result back, whether it be negative or positive, we see them again, and then we just take them through. What does a negative result mean? What does a positive result mean? All of those things. And it's like short enough.
Thank you guys so much for the listening and for lovely presentations. I think we're out of time.
We are.
Thank you.
We're over time.
And yeah, so please you can always catch the presentation on our website on the YouTubes. It's available and we can reshare it again. And I think it's been quite good discussion. Thank you so much.
I love the discussion.
And Michelle, thank you for organizing. We love it. Thank you. And
Thank
another
you.
ethic point in the back. Thank you.
Thanks.
Thank you.
Bye, everyone.
Thank you so much.